Welcome to our video on pharmacology of diuretics. After watching this video, you should be able to discuss the mechanism of action, side effects, and special uses of the different classes of diuretics. You should also be able to select the best class of diuretic for common clinical scenarios based on the drug's potency and secondary effects. What is a diuretic? Diuretics comes from the Greek verb urin, which means to urinate. In modern medicine, medications that increase renal salt and water excretion are called diuretics. What are the different classes of diuretics? Where and how do they work? What are their special uses? To target proximal tubular sodium reabsorption, we need to review how sodium is reabsorbed at this segment. Here we have a cell from the proximal tubule. First, sodium is reabsorbed in exchange for the secretion of hydrogen into the lumen via the sodium-hydrogen exchanger NHE3. Hydrogen combines with filtered bicarbonate to form carbonic acid. Carbonic anhydrase splits carbonic acid into CO2 and water. CO2 freely diffuses across the cell, while water crosses the cell via aquaporin channels. Inside the cell, carbonic anhydrase recombines CO2 and water to reconstitute carbonic acid. Carbonic acid then redissociates into a proton and bicarbonate. The proton returns to the lumen to pick up another bicarbonate to reabsorb, while the regenerated bicarbonate gets reabsorbed along with sodium into circulation via the sodium bicarbonate cotransporter. To block proximal tubular sodium reabsorption, we could technically inhibit anything that is involved in this multi-step process. So what do we have clinically that can block sodium reabsorption at this segment? Sodium reabsorption along with bicarbonate at the proximal tubule can be blocked by a class of diuretics called carbonic anhydrase inhibitors. Sulfanilamide was the original carbonic anhydrase inhibitor. However, when it first came out in the 1930s, the elixir sulfanilamide was improperly prepared with diethylene glycol and caused mass poisoning in the United States, reportedly resulting in more than 100 deaths. The public outcry caused by this incident and other similar disasters led to the passing of the 1938 Federal Food, Drug, and Cosmetic Act. What we do have now that is safe for use is acetazolamide. It is absorbed orally and excreted by the kidneys. In addition to blocking sodium reabsorption, what else can happen when we take acetazolamide? Inhibition of sodium bicarbonate reabsorption by acetazolamide can lead to metabolic acidosis due to the loss of bicarbonate into the urine and hypokalemia. The reasons for hypokalemia include: number one, potassium is positively charged. It will follow the negatively charged bicarbonate in the urine. Number two, with high sodium loss in the urine, volume depletion ensues, which leads to the activation of the renin-angiotensin-aldosterone system. Aldosterone enhances potassium secretion at the collecting tubules. As it turns out, acetazolamide is a weak diuretic. Number one, the effect of carbonic anhydrase inhibition is attenuated by the ensuing metabolic acidosis. What this means is, with the continuing bicarbonate loss into the urine caused by acetazolamide, the plasma bicarbonate level slowly decreases. As a result, there will be less bicarbonate filtered, thus less sodium bicarbonate that can be lost into the urine. Number two, with the inhibition of proximal sodium reabsorption, the escaped sodium gets reabsorbed downstream at distal segments. The increase in sodium reabsorption at distal segments reduces the total amount of sodium loss, thereby rendering acetazolamide a weak diuretic. That is, acetazolamide cannot cause a lot of urinary sodium loss. When do we use acetazolamide clinically? Because acetazolamide is a weak diuretic that also causes metabolic acidosis, it is typically only used as a secondary diuretic agent in cases where patient's blood is too alkalemic. That is, when the blood pH is increased due to a higher bicarbonate relative to proton concentration. Acetazolamide can be used to treat high-altitude sickness. The acetazolamide-induced metabolic acidosis leads to increased ventilation, thereby improving blood oxygenation at high altitude. Acetazolamide can also be used to treat glaucoma, a condition associated with very high pressures in the eye that can cause damage to optic nerves. Acetazolamide inhibits the formation of a fluid called aqueous humor within the eye, thereby lowering the pressure in the eyes in patients with glaucoma. A few notes regarding acetazolamide dosing. For chronic conditions, dose every other day to avoid the development of severe metabolic acidosis. Acetazolamide is contraindicated in patients with sulfur allergy. Going back to our nephron, we just discussed blocking sodium reabsorption in the proximal tubule with the diuretic carbonic anhydrase inhibitor, acetazolamide. Let's now learn about another class of diuretics that can block sodium reabsorption at the thick ascending limb of Henle loop. Diuretics that work at the loop of Henle are called loop diuretics. To target sodium reabsorption at the thick ascending limb of loop of Henle, we need to review how sodium is reabsorbed here. Here is a thick ascending limb of loop of Henle, apical and basolateral sites, and the ubiquitous basolateral sodium-potassium ATPase transporter. On the apical side, we have the sodium-potassium 2-chloride cotransporter, known as NKCC, which serves to reabsorb sodium, potassium, and chloride from the lumen. Once inside, sodium and chloride get reabsorbed back into circulation, while potassium recycles back out into the lumen. The recycling of potassium into the lumen creates a positively charged lumen, which serves to repel positively charged molecules, including calcium and magnesium, to be reabsorbed paracellularly. So what is available clinically to block sodium reabsorption at the thick ascending limb of Henle loop? We have a class of agents called loop diuretics that can block the activity of NKCC. Blocking NKCC causes urinary loss of sodium, potassium, and chloride. Potassium recycling, thus the generation of the positively charged lumen, ceases to exist. The loss of the positively charged lumen leads to the loss of calcium and magnesium into the urine because there will be no positive charges to repel calcium and magnesium paracellularly for reabsorption. Let's take a look at currently available loop diuretics. Loop diuretics are highly albumin bound in the plasma and need to be secreted into the tubular lumen via an organic anion transporter. Once transported into the lumen, loop diuretics bind to NKCC, where they exert their inhibitory effect on sodium reabsorption. This table lists clinically available loop diuretics. Bumetanide and furosemide are the two most commonly used loop diuretics. They are both more short-acting compared to torsemide. Bumetanide has a greater bioavailability compared to furosemide. This means 80% of orally administered bumetanide will be absorbed, while only 50% of orally administered furosemide is absorbed by the gut. Because of this, intravenous and oral dosing for bumetanide are similar, whereas for furosemide, with only 50% bioavailability, conversion of an intravenous to an oral dose is typically doubled. For example, if a patient is receiving 20 milligrams of furosemide intravenously, an equivalent oral dose is 40 milligrams. Bumetanide is about 40 times more potent compared to furosemide. The dose equivalent is 1:40. This means giving 1 milligram of bumetanide results in the same degree of diuresis as giving 40 milligrams of furosemide. Of note, loop diuretics are known for their ototoxicity, which may result in deafness. Since the diuretic potency of bumetanide is about 40 times that of furosemide, it is anticipated that blood levels necessary to produce ototoxicity for bumetanide will rarely be achieved. With the exception of ethacrynic acid, all loop diuretics contain sulfur. Because of this, patients with sulfur allergy can only use ethacrynic acid. Unfortunately, ethacrynic acid is highly ototoxic and is rarely ever used. Of interest, some experts believe that sulfur-containing loop diuretics are not as allergenic in sulfur-allergic individuals as previously thought. Patients who do need to use any of these sulfur-containing loop diuretics, either a desensitization protocol may be used, or patients may be given the drug with very close observation. Risks and benefits must be discussed with patients. Loop diuretics are the most potent diuretic of all diuretics for several reasons. First, there is a high amount of sodium loss. This is because loop diuretics block the reabsorption of a large portion of the filtered sodium that gets delivered to the thick ascending limb of Henle loop. There are no high-capacity segments distal to the thick ascending limb to reabsorb the increased sodium delivery. Loop diuretics disrupt tubuloglomerular feedback. Remember, tubuloglomerular feedback needs the macula densa at the distal thick ascending limb to sense chloride delivery. The chloride sensing mechanism at macula densa is actually via NKCC reabsorption of chloride. Loop diuretics block NKCC, thus the chloride sensing mechanism by macula densa. This allows for continuous high chloride loss without any tubular feedback to reduce glomerular filtration. Second, there is also a high amount of water loss. Inhibition of NKCC inhibits the sodium chloride reabsorption required to maintain the high medullary concentration gradient necessary for effective water reabsorption. The resulting reduced medullary tonicity leads to reduced water reabsorption at the collecting tubules. What are the secondary effects of loop diuretics? Hypokalemia is common. Reasons: number one, there is direct potassium loss from NKCC inhibition. Number two, the associated sodium loss leads to volume depletion, which activates the renin-angiotensin-aldosterone system, or RAS. Aldosterone, in turn, increases potassium secretion at the collecting duct. Number three, the increased sodium delivery from the thick ascending limb to the collecting duct also increases potassium secretion at this segment. Recall that at the collecting duct, sodium is reabsorbed in exchange for a potassium. Metabolic alkalosis, as evidenced by a high serum bicarbonate concentration, can also be seen. This is due to the associated activated RAS system. In addition to potassium secretion, aldosterone also increases hydrogen secretion at the collecting duct. Hypocalcemia and hypomagnesemia may also be seen with the use of loop diuretics. Finally, the use of loop diuretics may increase renal reabsorption of uric acid, which leads to hyperuricemia and precipitation of gout attacks in at-risk individuals. What are the best uses of loop diuretics? Since these are potent diuretics, we commonly use loop diuretics for fluid overloaded states, including congestive heart failure, fluid accumulation in patients with end-stage liver disease known as cirrhosis, and fluid accumulation in patients with nephrotic syndrome and peripheral edema. We may also use loop diuretics for hypertension in the setting of advanced kidney disease, where the kidneys can no longer adequately excrete the excess dietary sodium and water intake that contribute to hypertension. We can also use loop diuretics for severe hypercalcemia. Recall, blocking NKCC leads to reduced paracellular calcium reabsorption at the thick ascending limb of Henle loop. However, if loop diuretic is used for the sole purpose of alleviating hypercalcemia, watch out for hypovolemia, because loop diuretic is a potent diuretic. Common adverse effects of loop diuretics include hypovolemia and hypotension, kidney failure associated with hypovolemia and hypotension, and as we've discussed, electrolyte and acid-base disturbances including hypocalcemia, hypomagnesemia, hypokalemia, and metabolic alkalosis. Remember we mentioned earlier that acetazolamide is a weak diuretic and is not often used for its diuretic effect? As it turns out, acetazolamide is sometimes used as an add-on diuretic agent with a loop diuretic to counteract each other's acid-base disturbances. While loop diuretic causes metabolic alkalosis, acetazolamide causes the opposite, which is metabolic acidosis. However, the combined use of acetazolamide and loop diuretic is only used transiently in the inpatient setting when aggressive diuresis is required and severe metabolic alkalosis with the use of a loop diuretic alone is a problem. And finally, ototoxicity resulting in deafness is a well-known complication of loop diuretics, particularly when high dose is used. Going back to our nephron, we have now discussed blocking sodium reabsorption at the proximal tubule with the carbonic anhydrase inhibitor acetazolamide, and blocking sodium reabsorption at the thick ascending limb of Henle loop with loop diuretics. Let's now discuss how we can use diuretics to block sodium reabsorption at the distal convoluted tubule. Let's review how sodium is reabsorbed in the distal convoluted tubule, or DCT. Here is the DCT, luminal side on the left and basolateral on the right. The ubiquitous sodium-potassium ATPase. Shifting our attention to the apical side. The DCT has a transporter called the sodium chloride cotransporter, or NCC. NCC reabsorbs filtered sodium and chloride back into circulation. Sodium reabsorption here can be blocked by a class of diuretics called thiazide diuretics. Because of this, NCC is also referred to as the thiazide-sensitive channel. The distal convoluted tubule is also involved in calcium reabsorption. Here, calcium is reabsorbed at the apical surface via a calcium channel, then back into circulation via the sodium-calcium exchanger. Of note, when thiazide diuretics block apical sodium reabsorption, it makes it easier for sodium to enter the cell from the basolateral side via the sodium-calcium exchanger. This leads to increased sodium-calcium exchanger activity, which in turn facilitates more luminal calcium to be reabsorbed via the apical calcium channel. Inhibition of NCC with thiazide diuretics, therefore, may lead to hypercalcemia in susceptible individuals. A few words about commonly used thiazide diuretics. Thiazide and thiazide-like diuretics are weak diuretics because they act distally. Most of the filtered sodium have already been reabsorbed at more proximal nephron segments. Thiazide diuretics are typically ineffective as diuretic agents for patients with very advanced or end-stage kidney disease. Agents with longer half-life, including chlorthalidone and indapamide, may reduce blood pressure better and confer greater risk reduction in congestive heart failure and cardiovascular events compared with hydrochlorothiazide. Chlorothiazide and metolazone are commonly used in combination with loop diuretics to synergistically increase diuresis in refractory cases of volume overload. Chlorothiazide is the only thiazide available for both oral and intravenous routes of administration. What are the common clinical uses of thiazide diuretics? The most common use of thiazide diuretics is in the treatment of hypertension. Thiazide diuretics exert both a mild diuretic and vasodilating effect. The latter is thought to play the major role in providing the antihypertensive effects. Because thiazide diuretics increase calcium reabsorption, the use of a thiazide diuretic may be preferentially considered over other antihypertensive agents in individuals with high risk for osteoporosis for the potential benefit of fracture risk reduction. Clinically, we commonly use thiazides such as metolazone and chlorothiazide in combination with a loop diuretic to treat refractory cases of volume overload. Since thiazides can increase calcium reabsorption, thus leaving less calcium in the urinary tract to form stones, we use it in patients with calcium stones due to hypercalciuria. What are the most common adverse effects of thiazide diuretics? Hyponatremia is not uncommon, especially among the elderly and malnourished individuals. The reason for hyponatremia is due to increased free water reabsorption at the collecting ducts. This effect is most pronounced with thiazide diuretics compared with all other diuretics. Hypokalemia is commonly observed. Similar to loop diuretics, hypokalemia occurs because, number one, the associated sodium loss leads to hypovolemia, activation of the renin-angiotensin-aldosterone system, thus aldosterone-induced potassium secretion at the collecting duct. Number two, the increase in sodium delivery to the collecting duct also enhances potassium secretion from principal cells at this segment. There may also be glucose intolerance in at-risk individuals, presumably due to reduced insulin secretion from pancreatic islet cells associated with hypokalemia. Other electrolyte and metabolic disturbances include hypercalcemia due to increased calcium reabsorption at both proximal tubules and distal convoluted tubules, hyperuricemia due to reduced uric acid excretion, which increases risk of gout precipitation in susceptible individuals, and hyperlipidemia, although this is thought to be a transient effect only. Going back to our nephron, we have now discussed blocking sodium reabsorption at the proximal tubule with the carbonic anhydrase inhibitor acetazolamide, blocking sodium reabsorption at the thick ascending limb of Henle loop with loop diuretics, and blocking sodium reabsorption at the distal convoluted tubule with thiazide diuretics. Let's now learn about diuretics that can block sodium reabsorption at the collecting ducts. Let's review how sodium is reabsorbed at the collecting duct. There are three distinct cell types at the collecting duct: principal, alpha intercalated, and beta intercalated cells. In terms of sodium reabsorption, we can skip talking about the beta intercalated cell. At the collecting duct, sodium reabsorption occurs via the epithelial sodium channel, or ENaC. Once sodium gets reabsorbed, it is transported back into the blood via sodium-potassium ATPase. The entry of sodium into principal cells creates a negatively charged lumen. The basolateral reabsorption of sodium via sodium-potassium ATPase leads to intracellular potassium accumulation. Both the negatively charged lumen and high intracellular potassium concentration favor potassium secretion into the lumen. This is how potassium is secreted in the kidneys. Next door, we have the alpha intercalated cell. This cell is equipped with a proton transporter called hydrogen ATPase. Intracellular hydrogen also likes the negatively charged lumen and gets secreted into the lumen via hydrogen ATPase. This is predominantly how the kidneys get rid of acid. Next, we have aldosterone. Aldosterone is a hormone that binds to mineralocorticoid receptors within the cytoplasm of principal and alpha intercalated cells to upregulate sodium reabsorption and subsequent secretion of potassium and hydrogen. So how can we block sodium reabsorption at the collecting duct? We can either block ENaC or mineralocorticoid receptors. Note that blocking sodium reabsorption at collecting ducts by either ENaC inhibitors or mineralocorticoid receptor antagonists will also limit potassium and hydrogen secretion because the secretion of both potassium and hydrogen depend on intracellular sodium entry via ENaC. The retention of potassium and hydrogen can manifest clinically as hyperkalemia and metabolic acidosis, respectively. Let's take a look at clinically available ENaC inhibitors and MRAs. Direct ENaC inhibitors include amiloride and triamterene. Commonly used MRAs include spironolactone and eplerenone. Since both ENaC inhibitors and MRAs also limit potassium secretion as opposed to potassium wasting seen with all other classes of diuretics, these agents are collectively known as potassium-sparing diuretics. Note that potassium-sparing diuretics are weak diuretics because they work distally where most of the filtered sodium have already been reabsorbed by more proximal segments. Let's now discuss a few characteristics about these agents. Spironolactone is a non-selective MRA. It does not just bind to mineralocorticoid receptors, but also to sex hormone receptors. Because of this, spironolactone can cause breast tissue enlargement, called gynecomastia, which may not be well tolerated by male patients. Eplerenone, on the other hand, is a relatively selective MRA that does not have high affinity for sex hormone receptors and do not cause gynecomastia. Amiloride and triamterene are both ENaC inhibitors, but amiloride is more commonly used because triamterene may precipitate as stones in susceptible individuals. We've discussed the two MRAs, spironolactone and eplerenone. Finerenone is an MRA that was FDA approved July 2021. It is a highly selective MRA that has no sexual side effects. Currently, finerenone is approved for use in patients with chronic kidney disease and diabetes mellitus type 2 for its anti-fibrotic effects for cardio and renal protection. This table compares basic properties of the three clinically available MRAs for your reference. What are common clinical uses of potassium-sparing diuretics? MRAs may be used in heart failure. They may be used as an adjunct to other antihypertensive agents, particularly in difficult-to-treat hypertension cases. They may be used in combination with a potassium-wasting diuretic. Example, a diuretic combination that is commonly used clinically is a loop diuretic such as furosemide or bumetanide, plus an MRA such as spironolactone. Blocking sodium reabsorption at different nephron segments by different classes of diuretics can potentiate sodium excretion. Additionally, while the loop diuretic causes potassium wasting, spironolactone limits potassium loss. This drug combination can therefore minimize potassium disturbances. MRAs may be used in patients with hyperaldosteronism associated with hyperfunctioning adrenals. Amiloride, a direct ENaC inhibitor, may be used for patients with gain-of-function mutation of ENaC known as Liddle syndrome. In this condition, sodium reabsorption occurs excessively because the mutated ENaCs cannot be degraded normally and are present in excess on the apical side of collecting ducts. Increased sodium reabsorption via ENaC in Liddle syndrome is responsible for hypertension in this condition. One very important note. Because potassium-sparing diuretics inhibit potassium secretion and can cause hyperkalemia, these agents should be used with great caution in patients with poor kidney function because these patients already have reduced capacity to secrete potassium. Using a potassium-sparing diuretic in these patients may easily cause life-threatening hyperkalemia. Let's summarize the different classes of diuretics and their sites of action. At the proximal tubule, we have acetazolamide, a carbonic anhydrase inhibitor that blocks sodium bicarbonate reabsorption. Acetazolamide is a weak diuretic because most of the escaped sodium gets reabsorbed by more distal segments. The use of acetazolamide is associated with metabolic acidosis and hypokalemia. At the thick ascending limb of Henle loop, we have loop diuretics such as furosemide and bumetanide that block NKCC. These are potent diuretics and can induce high sodium loss. Loop diuretics can cause metabolic alkalosis, hypokalemia, hypocalcemia, and hypomagnesemia. At the distal convoluted tubule, we have thiazide diuretics such as chlorthalidone and metolazone that block NCC. These are weak diuretics because most of the filtered sodium have already been reabsorbed at more proximal segments. Thiazides are associated with hyponatremia, hypokalemia, and hypomagnesemia. Of note, thiazides are associated with hypercalcemia, not hypocalcemia as seen with other classes of diuretics. Additionally, thiazides can increase uric acid reabsorption, thus hyperuricemia, and predispose at-risk individuals to gout attacks. Finally, at the collecting duct, we have potassium-sparing diuretics including ENaC inhibitors, namely amiloride and triamterene, and MRAs such as spironolactone, eplerenone, and finerenone. These agents are weak diuretics and are associated with metabolic acidosis and hyperkalemia. Finally, a quick review on special uses of diuretics. The carbonic anhydrase inhibitor acetazolamide may be used to treat glaucoma or high-altitude sickness, or used in combination with a loop diuretic to minimize acid-base disturbances while synergistically increase the diuretic effect. Loop diuretics may be used to treat volume overloaded states, as seen in heart failure, and fluid accumulation seen in patients with nephrotic syndrome or end-stage liver disease known as cirrhosis, hypertension in advanced kidney disease, or hypercalcemia. Thiazide diuretics are commonly used to treat hypertension or calcium stones. In many cases, thiazides are used in combination with a loop diuretic to synergistically increase the diuretic effect in patients with severe volume overload. The potassium-sparing diuretic amiloride may be used to treat Liddle syndrome, a condition where there is excess ENaC activity. MRAs may be used in patients with heart failure, aldosterone excess states, or add-on therapy for difficult-to-treat hypertension. MRAs may also be used in combination with a loop diuretic to potentiate diuresis in patients with severe volume overload. At this time, you should be able to discuss the mechanism of action, side effects, and special uses of different classes of diuretics. You should also be able to select the best class of diuretic for common clinical scenarios based on the drug's potency and secondary effects. That's it for this video.